Okay, so I welcome you all for the today's lecture on clinical governance. And as I was saying that in previously it was important topic for the MRCUG students, but currently the FCPS students are also getting some questions over the clinical governance. So that's why I made this lecture as a as an open lecture for everyone, so that the FCPS as well as MRCUG students can get some benefit from it. We will be starting with the scenario. I am waiting for one of my students to join in so they can solve the scenario, and then we can have a discussion over it. So the topics we are going to discuss today, they are going to be the risk management, because whenever there is some problem in terms that whenever some incident happens, then the risk management is very important part of the management system. In most of the cases, like in setups like Pakistan, usually it happens that the risk management, the clinical governance, the audit, these things do not happen. But in UK setup, whenever there is some incidents that has happened, for example, any kind of emergency incident that has happened, I will be showing you a list today in the today's discussion. So there becomes an incident report that is generated at that time that this incident has happened. And after the incident report happens, then they properly study that what was the risk factors for this, how the risk management was done, and they do perform the clinical audits over it. So the today's topics are going to be the risk management. I'm going to discuss the maternity dashboard with every one of you. I'm going to discuss about the audit, and I'm going to discuss about the appraisal of audit. So these few topics are going to be a part of our today's discussion. So is there any MRCUG student out there who can solve the station? Okay, so let's start with the presentation over the risk management. I'm going to discuss with you the risk management, and then I will be telling you with the help of an example or a scenario that how we do the risk management in this particular case. So I'm going to skip the station because currently no MRCG student is here. Okay, so let's start with the components of a risk management. So the risk management is basically based upon the five pillars that are the most important part of the risk management. Okay, so the risk management basically it starts with the risk identification, in which we identify that what are the problems. Then we go with the risk analysis, and after the risk analysis, we go with some kind of planning, implementation, and the tracking. The today's lecture is going to be slightly boring for everyone because the risk, the audit topics, these are slightly dry. But I have tried to make them slightly easier for you so that everyone can understand that. So I'm going to start stepwise. So the first thing is the risk identification. So what is meant by risk identification? That whenever this is a scenario, this was a scenario that is given. Here, what happened was that there was a patient who underwent a transabdominal hysterectomy and bilateral salpingo-oophorectomy for her endometrial hyperplasia. And in the post-operative time period, she had a pulmonary embolism. So she was overall fit and well, but the BMI was 44 and she was already taking BD prophylaxis. Afterwards, what happened on the first post-op day was that everything was given to her and heparin was given in a prophylactic dose to her. At that time, her new score was 3. What happened on the second day was that on the evening of second day, the heparin was missed. The heparin was not given to her. And on third post-op day, she started having some chest pain and difficulty in breathing, which means that she had a pulmonary embolism episode. So her ABC was done, and the pulmonary embolism was diagnosed on CTPA, and the low molecular weight heparin was started in a treatment dose to her. So this is the case that we are having, and I will be explaining you that how we do the risk management in this kind of case or in any kind of case that we come across. So if we go about the factors or if we go about the components of the risk management, the first component is that first of all we have to identify the risk identification.
Most of the time that is used to seen in 6% of cases.
Sorry, what are you saying? Is anyone asking a question, please? Okay. Okay, so the first thing that we do in the risk management is we identify the risk, that what was the risk. See, the risk that happened was that pulmonary embolism happened to this patient. Risk identification means what happened. And how we can see that, how we identify the risks. There are certain ways to identify the risk, like sometimes there are some incident report forms, there are some risk registers, like in all of us are having certain registers in our units. For example, there is a mortality register in some units, there is a risk register in some units. So with the help of these registers we are able to identify that what things happened. Then we notify the risk management team, and then sometimes the patient also complains about something, because whenever some complaint happens, the patient can complain regarding it. So these are all the things by which we are able to identify that some risk happened or some problem happened. Talking about the incident reporting is recently gaining very much importance in the Mrcog exams and in the FCPS exams as well. Regarding the incident reporting, I will be showing you certain slides that what are the things on which we are able to initiate an incident report. What an incident report means, that there is basically a form, a simple form on which you mention that what was the incident that happened, at what time the incident happened, and who has been notifying it. For example, you are a PG1 or you are a PG2 that that came to know about a scenario of pulmonary embolism, and you fill the incident report form. So anyone in the team can fill the incident report form. So this is the risk identification, that what happened. So the risk identification, for risk identification, there are different sources, that there can be incident reports. Sometimes the patients can complain regarding it. Sometimes we have the registers from which we get the data. So these are all the things by which we come to know about the risks. Okay, so the incident reporting triggers, I'm going to discuss it with you. So this is a list of triggers upon which we generate the incident report. Like there are some maternal incidents, some fetal incidents, and there are some organizational incidents. You can see it here that whenever any of these incidents will happen, you will initiate an incident report for that. For example, the maternal incidents can be the death, the undiagnosed breech. The breech has been coming in the FCPS exams in the past. The shoulder dystocia, if the blood loss is more than 1500 ml, if for any complication the patient has to return to the theater, if it is eclampsia, if there is an unplanned hysterectomy like an obstetric hysterectomy, if there are any anesthesia complications, any ICU admissions, venous thromboembolism, pulmonary embolism. See our cases about pulmonary embolism today. Any third or fourth degree tears, unsuccessful instruments, uterine rupture. Similarly, there can be some neonatal incidents, like there is a stillbirth, there is some neonatal death, there is APGAR scoreless, the birth trauma. These are a bit difficult to remember for everyone. So just speaking journal on a journal background, that whenever any complication has happened in your unit, whenever any complication has happened that was not supposed to happen, like a breach was not diagnosed till the term, and it was a booked patient, like a mother, she suddenly died, like there a stillbirth happened, like the baby started having some seizures, baby started having some birth trauma, there was third or fourth degree complication. Whenever they are there. Okay, so if any kind of incidents that have happened, so all of these are some triggers to the incident report. Kindly mute the mics, everyone, so that everyone can clearly listen to the things. Okay, so any kind of incident that has happened in your unit is you can write an incident report about that if you are unable to remember all these incidents. Although these incidents have been coming in RCOG, and these are a list that RCOG has provided us about what can be the incidents for reporting. So this is a list for obstetrics, and I will also have a list for gynae as well. Like if there is damage to any of the structures, there are any complications, any venous thromboembolism that has happened. So these are some incidents. So you can remember that list on a journal ground. You can remember that any incident that has happened in the department that was not supposed to happen, or that has happened due to any kind of carelessness, comes under the incident reporting trigger. So you will generate an incident report for that. Okay, so the first step was the risk identification, in which we identify that what was the risk. The second thing is the risk analysis. Now, once we have identified that what problem has happened, now we will see that how it happened. What were the factors that made it happen? So first of all, we make an investigation team to sit upon it, and the team decides that what are the things that could have been a contributory factor towards the risk happening. In the team, you always select the consultant, you select the risk management lead, you select the hematologist in this case because it was a case of pulmonary embolism. And because it is a case of pulmonary embolism, so the team will involve the intensivist and the specialist nurse as well. So
Glass.
in case you will select your list that what team is going to investigate what happened and how it happened. So afterwards, you see that interview the staff that is involved after any incident. I am talking about the risk management in general. Whatever case comes to you, just apply these points on that, and you will be able to do your station. Like for the risk analysis, we will interview the staff. We will ask the staff that what happened, why the dose was not given to the patient, why heparin was missed for that patient, when it happened, was there a specific reason for that. But there is one very important thing in the clinical governance issues, that whenever somebody has committed a mistake, you should avoid the blaming policy for them, and you should be like hard on the issues and soft on the individuals. What does this sentence mean? This means that you should address the issues and you should try to solve them in future, but you should not scold the junior, or if somebody has done the mistake, it's not a good thing that you are going to blame them for the whole incident. It's a good thing that you tell them that this mistake has happened and now they have to correct it, or now it has to be corrected, so you have to sort out the ways to correct it rather than blaming your colleague. So in risk analysis comes, first of all, we make a team, then we interview the staff about it, then we evaluate that why did it happen. And for evaluation, there are certain models that are available. One is called as root cause analysis, in which we collect all the facts and we analyze the facts that why it happened, and then we draw a conclusion. And one very important one is here is fishbone diagram, which comes in the risk analysis. What fishbone diagram means that there are certain causes for an effect to take. Let me explain it to you this way, that there can be some problems related to the machine, there can be some problems related to the method, related to there can be some manpower problems, like there can be a lot of factors that are causing this problem. So what was the problem that pulmonary embolism happened, and what were the causes for it? Let me tell you. Okay, so there can be different causes, like there can be some environmental factors, there can be some patient factors. For example, the pulmonary embolism happened. So what can be the patient factors? The BMI of the patient was 44. The surgery was performed on the patient. The post-operatively VTE was not properly given to the patient. We have to check about the mobilization and hydration of the patient, that whether it was the patient factors that caused it, whether there were any environmental factors, there were any communication factors, because heparin was not given. Maybe one shift did not give the proper over to the next shift. It was a busy unit. There can be communication gap. There can be some resources problem, like it can be short in the ward. There can be some organizational factors, like it can be a busy unit. That's why everyone forgot to give her the prophylaxis. So these are all the factors that are contributing to a cause. So this is called as fishbone model, in which there are different causes that lead to an effect, which means that there were different factors like the patient factors, environmental factors, task factors, communication factors, that led to the effect that the patient did not receive the medicine and the patient underwent a VTE. Okay, so afterwards, so this is these are up till now we have studied three components of the risk management. The first one was risk identification, that what happened. The second part is the risk analysis, that how it happened. The third part is the risk evaluation, that why did it happen. And the last part we have is, okay, so risk management, there is one important concept about the risk management as well, that I'm just muting the mics. Please mute the mics yourself so that there is no disruption. Okay, so let me tell you about the risk management. There are two things. You can see that first of all, it is written impossible, unlikely, low, moderate, high, and certain. This means that this is the likelihood of a problem happening. And on the other side, you can see that the severity is mentioned: nil, low, moderate, serious, high, or above tolerance. So based on this table, there is a scoring available. For example, if there is some risk factor that is whose likelihood is that it will never happen, it is impossible, and the severity is negligible. Like even if it happened, the severity would have been very low, but it is impossible to happen. So the score here, you can see the score here would be 0. And if there is some incident that is very likely to happen and that is very fatal, so means its tolerance, it was above tolerance and it is certain to happen. So this means that the score would be 25. So this is how we score the severity and the likelihood. This is not very important for any of the exams, but I just wanted to show to you that how we score the risk management. Okay, so then comes, currently we have read three components: the risk identification, the risk analysis, the risk evaluation, and now comes the risk treatment. Now, we have identified one thing, that why something happened, like pulmonary embolism happened, why it happened. Now, what are we going to do? We are going to draw a conclusion about it, and we are going to solve the problem. That's what we do. So here what we do is that we will devise an action plan. We will try to train our individuals. We will train them that how it is administered. We will do proper training of the cold chain. We will make the students learn about the administration. We will tell our staff that it should be properly stored, and we will change the practice. So these are the certain points. If any case comes, you can go accordingly, like what things were to improve in this specific case. It's not only about pulmonary embolism, but whenever any kind of case comes, you should have to draw a conclusion that this is how it could have been done in a better way. So after that comes the risk control, that when a mistake happens, we learn from it. So in the risk control, we basically learn from it. And how we learn from it: whenever a case happens, we properly arrange a feedback session over it, that this was the complication that happened. Like we all do in our clinical cases, we arrange a proper session over it, a proper feedback session over it. We do some educational meetings. And one of the very important component of risk control is the audit. Audit is done so that we can get, we can get to know that why the thing happened. And by auditing the thing, we basically control the damage, or we correct the things, or we correct the procedures that are going wrong, or the practices that are going wrong. So this is how we control the risk. So this is basically a whole loop. Okay, so coming to the clinical governance issues, whenever any incident has happened or whenever any complication has happened, there are 5 Ds that you have to address. The first thing is that you have to document the procedure or the problem that happened. Then you have to debrief the patient, which means that you should tell the patient that what happened, and you have to be very open and honest about it. Then you will do the duty of candor. The duty of candor means that you will apologize to the patient for your mistake or for the mistake of anyone, and you will do the duty of candor. The datics means incident reporting that you will do, and the drills mean that what you are going to do now. For example, a perforation has happened to the patient. First of all, you document it, then you tell the patient that a perforation has happened. Then you do the duty of candor. You apologize that this happened, although this was not supposed to happen, but because this happened, we apologize to you, and we will be looking into the matter, and we will generate an incident report over it. That X means incident report, and drills mean that what are we going to do now? We are going to perform a laparoscopy to correct the perforation or whatsoever the complication has happened. So this is how we take a case where any problem has happened. So is anyone having any problems about the risk management? They can ask me now, so we can go to the next topics. Is anyone having any questions, please? Okay, so I'm going to revise it once more for you about the risk management. The next topic is maternity dashboard, and the last one is audit. Okay, so here we had 5 components of the risk management. The first one was risk identification, and how we identify it, I told you that. Then comes the risk analysis, that how it happened. Then comes the risk evaluation, that why did it happen, and we do it by a fishbone model. And the last one is the, okay, I have one question. Okay, so Dr. Aisha Zain, basically, I would like to tell you that clinical governance and risk management are not the same. Basically, the clinical governance has 7 pillars, and one of them is risk management. But generally, in our scenarios, we need 2 or 3 things in for the FCPS perspective. Like we require the risk management, we require to know about the audit, we require to know about the appraisal of audit, and we require to know about the incident reporting. Clinical governance basically has 7 pillars. One of them is risk management. Let me tell you the pillars of the clinical governance. One of them is clinical audit. One of them is clinical effectiveness. One of them is risk management. One of them is use of information, education, and training. Then there is staff management, and then there is some like client or career experience. So you can say that audit is one of the pillar and risk management is one of the pillar. And these are the 2 components that come in the exam most of the times. Overall, the risk clinical governance has 7 pillars that I just told you. So I have one more query. Yes, Rubina, the recording will be available to everyone. Hopefully I will be uploading it on Facebook, but I'm not sure whether I will be able to like make it public or not. But for the students, group students, it will definitely be there. But I will try to upload on the Facebook as well. So even if anyone is not able to finish it, they will be having an access to it. Okay, so this was the one of the like pillars that is risk management. So is anyone having any other question about it? Okay. Okay, I think there are no more questions. Rubina, are you here?
Yes, I'm here, Dr. Nadesh.
Okay, so Rubina, will you like to solve the maternity board for us?
Yes, Dr. Nadesh, I can.
Okay, okay. Okay, so we are going to solve a maternity dashboard. And after solving the maternity dashboard, I will be teaching you about the maternity dashboard as well. Okay, so Rubina, take your 2 minutes.
Okay.
Okay, so can you tell me what is the maternity dashboard and what are our goals about it?
Yes, maternity dashboard is the clinical governance dashboard. It is generally a review of the monthly activity of a maternity unit, and by which we are able to analyze what was going on in the month and how we can improve things.
Okay, and can you tell me that how is it displayed and what are the parameters?
It is displayed on a screen so that all the stakeholders, including the midwives, the doctors, and all of those who are involved in patient care, are able to see that. And it is basically, it includes 4 parameters. That is the clinical activity of the maternity unit, the workforce, the clinical outcome, and the patient feedback. So in the clinical activity, we see that how many midwives and how many doctors are there on the duty, how many hours is the consultant present, and how are the things going on, and how many deliveries being conducting, how many are the VBACs, how many forceps or ventouse applied, and how many cesarean sections, and about the clinical outcome. We get to know about the clinical outcome, like how many clinical outcome, as we see the maternal outcome and the neonatal outcome. What the factors, like the things that need to be reported, like OSS, anus sphincter injuries, failed forceps, or successful VBACs, or any events that occur that needs incident reporting. How many were they? And about the workforce, we get to see how many deliveries are being conducted, and is the one-to-one ratio of patient to midwife is being met or not. So how many, what is the attendance of the people that are working in a maternity unit. And in the patient satisfaction survey and the patient outcome, we see that what are the patient reviews and how much are how is their feedback, are they satisfied, or what are their complaints. Not only by this, we get to review the activity of the whole maternity unit, but we get the fair idea how the things can be approved. We get to see our results on the amber zone, red zone, or the green zone. So we, after having a whole look of it, everyone understands that said what is going on and how the things can be improved. Not only that, we are able to monitor the activity going around in one maternity unit. We are able to compare it with other units as well.
Okay, so can you comment on this maternity dashboard regarding the cesarean sections, and what do you think that seeing this maternity dashboard, what could be the possible causes of like increased cesarean section rate? What do you think about it based on this maternity dashboard? Please interpret it.
Okay. In the clinical activity section, I can see that the goal was to keep the cesarean section rate under 23, but it is more than 25, and cesarean birth rate was measured. If the comments are, if more than 30%, then cap and refer to the other providers. And the data source, it has commented in January, it was crossing the limit, it was more than 25%. And in February, March, April, and May, it was like in the it was 23, and in the June, July, August, maybe after getting to know the result and implementing certain changes, it came to lie within the limits, and it is 19%, then 21%, and in August it is 20%. In September, it is again in 23%. According to the NICE guideline, the cesarean section rate should be is between 25 to 30%, and here they say that it will come to lie if it is more than 25%. So it is not the target achieved actually. So in 3 months the target was achieved, but in 4 of the months it went in the amber zone, but only in January it was 25. If we see across the year, the things get improved.
Okay, so Rubina, can you tell me about some advantages and disadvantages of the maternity dashboard?
Actually, the advantages of it are we are able to see and review our activity, and the whatever provided are according to the standards, or they are not according to the standards. And after that, having a look on that, give us a fair idea about that. And then once we see the root cause analysis, then look back into the things. Just a minute, don't manage. 1 minute, please.
No problem.
After just having a look onto the maternity dashboard, we are able to see what things need immediate attention, and how things can be brought from high risk to low risk. And if we talk about the disadvantages of that, generally healthcare staff or the doctor take it as a burden. It seems like that it is an additional duty to them, and people think that people are not generally aware that it does not mean to someone, or it is only to improve the quality of healthcare services that we healthcare providers are providing to the patient.
Okay, thank you so much, Rubina. Okay, so Rubina has very beautifully told everything about the maternity dashboard, and I'm going to take it somewhat further as well. First of all, I will be explaining you about the maternity dashboard, that how we interpret that maternity dashboard. Basically, just we talked about the risk management, and in risk management, one of the point was that how do we identify the risk, that what risk has happened. So the maternity dashboard is there, the labor ward registers are there, the different incident reports are there. So there are different ways to gather the data. Maternity dashboard is basically a graphical representation. It is a representation of the thing that what things are going wrong in the department and what things are going right in the department. So first of all, I'm going to discuss with you. It is basically a tool that is employed to monitor the changes and for the implementation of the clinical governance. If I'm going to make it easier for you, you can see here there are three colors you can see on the maternity dashboard. The first one is green, the second one is amber, and the third one is red. So the green ones mean that you are in the best possible range, like you are going fine. The amber means you need to be alert because you are in the upper threshold, and with the slight further increase, you will go above the threshold. And the red means that the threshold has been breached and now you are in the danger zone. You know the traffic light system goes as green, yellow, and red. So same way the maternity dashboard is made in such a way that when you look over it, it is basically displayed in the labor wards in UK. So when you have a look at it, you come to know that okay, what things are going wrong in the department and what things need a correction. So whenever we are performing an audit or whenever we are performing a risk management, we take the data from the maternity dashboard as well. So starting from the starting from the very right corner, there is written activity, workforce, and clinical indicators. So there are different things that are to be monitored that are written here, like the births, the scheduled bookings, the cesarean section, the staff level, the maternal morbidity. Can everyone see the arrow here? I'm pointing to see the activity, that is birth, bookings, cesareans, then the workforce, staff levels, maternal morbidity, neonatal morbidity, risk management. So all of these indicators are written over here. Green means the goals. Goal means that if you are in this range, you are in a correct range, which means that suppose we had a cesarean section taken and there was less than 23% cesareans in the department. This means that you are in the green zone and you are going fine. But if you exceed more than 25% cesarean section rate, this means that now it is a danger zone achieved. So now you have to take certain actions over it so that you come back to 23%. Sometimes the maternity dashboard findings are interrelatable as well. Like you can see that when cesarean section rate is going higher here in this zone, it is in red and yellow zone. So at the same time, you can see that the midwife birth ratio is also going in a higher range. You can see that the supervisor to midwife ratio, it is less as well, this one. So there are many things that are interrelated. Basically many things can be seen from the same labor board. Like you can see that when the midwife ratio, when the births are increasing at the midwife ratio, the midwife units, then in those cases the cesarean section rate is increasing a lot. Where the instrumental birds have gone in the yellow zone, in those zones, the cesarean section is increasing. So you have to basically interrelate the different findings from the maternity dashboard. So when the consultant, for example, if the consultant is not present in the unit, the consultant's presence, see, this is weekly hours of consultant cover on the labor board. So you can see that when the weekly cover of when the consultant is not present in the ward, then in those zones the cesarean section rate is maximum, which means that if the consultant is not present, the cesarean section rate is rising. When the home birth is rising, the cesarean section rate is rising. So these basically parameters are interrelated, that upon looking upon one parameter we are able to predict that why it is, how it is affecting the second thing. So these are basically interrelated, and you get to know there are many like advantages of the maternity dashboard. The first thing is that upon looking at the maternity dashboard, you are very easily able to identify the problems. Like you can see here that cesarean section rate is definitely rising. So here some measures have been done after which the cesarean section rate has come to a normal range. Here you can see that in this zone, you can see that here this one is the red zone, this one is the red zone, these things need an attention. These are the green zones, they are fine. So accordingly, we interpret the maternity dashboard. First of all, we look here upon the parameters, then we look what are our goals, then we look what are the red flags. Usually the comments are not very important for the maternity dashboard, but you should be knowing that when we have to do what. For example, if I talk about the cesarean, if it is less than 23, it is normal. If it is more than 25, it comes in the red zone. And the comment is that if it goes more than 30%, then it is better to refer to some other provider. The data source is statics means incident report. That via incident report you were able to pick that up. So this is about the maternity dashboard. If anyone is not able to understand the maternity dashboard, that how to read it, just let me know so that I can explain it before going further. Is everyone clear about how maternity dashboard can be read, like how you can interpret the maternity dashboard if it comes in exam? Generally, the maternity dashboard itself will not be come as for interpretation, but sometimes they may give some questions from it. Like I just gave Rubina a question that if cesarean happens, what will happen? Okay, someone is okay. So Sarah, what do you want to ask about the maternity dashboard? Okay, let me explain it again. This is basically a graphic representation of different parameters. On this side, the parameter is written like, for example, the births in this unit, the cesarean sections in this unit, the staff level at this unit. This is what we have to see. The maternal morbidity, for example, eclampsia, ICU admissions, blood transfusions, whatever we have to look at, we write it here. Then we make a goal that this is the goal. For example, if the cesarean section is the parameter, the goal is that if the cesarean section rate in any unit is less than 23%, this means it is a green one. Green means that it is a normal rate. If it is going more than 25, this is an alarming sign for us that why the cesarean section rate has increased so much. So after that, we see that in January, the rate was 25.5, which means it is a red zone. This means that the cesarean section rate was drastically increased. In February, we can see that it was yellow, which means that it was in a danger zone as well. In March, April, and May, we can see that it was a lot. So in June, we can see that the cesarean section rate has fallen to normal. So this is how we see the maternity dashboard. Sarah, are you able to read it now? Can you unmute your mic? I will give you an example. Okay, so Sarah, let's see that we are looking towards. Okay, so let's see, we have the parameter maternal morbidity and ICU admission in obstetrics. Can you see it? Okay, so is anyone having any confusion about it? I can re-explain it. Okay, I'm going to read one more parameter for you for the better understanding. For example, we come to the maternal morbidity and different things are written over here like eclampsia, ICU admission, blood transfusion. Then we have postpartum hysterectomies. Okay, so the postpartum is, see the ICU admission in obstetric unit, if it is less than 6 cases, this means that our goal is being achieved and it is in a safer zone. And if the cases exceed 6, then this means that it is a dangerous thing that the ICU admissions in obstetrics are raising. So when we see the maternity dashboard of January, February, March, there are 0 admissions. In April, there is 1 admission. In May, there is 0. June, July, 0. August, there is 1 admission. And September, there is 1 admission as well. So all of these are in the normal zone. They are in the green range. So that's why less than 6 cases means that it is a green thing, which means it is a good thing. If it had been in red zone, for example, if it was more than 6, it were 7 admissions in the ICU unit in that particular month, then it would have been an alarming sign that something is wrong. Okay, Dr. Aisha, I'm going to repeat it again. Okay, so we take basically any parameter from the maternity dashboard. These are the parameters that we have to monitor, and there the goal is written. For example, I'm going to discuss something else now. Um, okay, so here I'm going to discuss about failed instrumental delivery now. This is my parameter that I'm going to look in the maternity dashboard, and my target is less than 1%. And the red flag is more than 3%. This means that if there is less than 1% failed instrumental delivery, that is not an alarming sign, that is the green zone. Green means we are safe. Amber means that the upper threshold has been reached and we have to be careful. And red means that now we are in the danger zone and we need to do something to be back in the green zone. So here the failed instrument, if it is less than 1%, it comes in the green zone. And if it is more than 3%, it comes in the danger zone. Here the months are written. So in the month of January, we can see that the rate was zero point 0.8, in February 0.8, in March 0.7, in April 0.9, in May 0.7, in June 0.5, in July 0.2, in August 0.2, and in September 0.2. This means that we have not exceeded the limit. That's why we are in the green zone. Is everyone clear about it, or should I repeat it once more?
चोको ब्लेस छोटी सी है फिर भी 4 हाँ जी
Okay, so
I have a question, Dr. Nazish.
yes, please, who is asking?
It's Rubina here.
Yes, please, Rubina.
Dr. Nazish, you asked me what are the disadvantages of that. I don't know much about that. If you can please explain to us.
Yes, I'm going to answer that, Rubina. I'm going to answer each and every question that I've asked you regarding the disadvantages. See, basically, the advantages we know that we can change the practice by it, but the disadvantages that it needs some dedicated manpower, it needs the IT system involvement as well, and it increases the workload on the unit, and it increases some extra paperwork. So whenever any kind of data is to be done, or any kind of data filling is to be done, for example, you have to maintain some register, you have to maintain some data. So the disadvantage is only the time and the manpower.
Okay.
Otherwise, all the other are the advantages of it.
Okay. Thank you, Dr. Nazish.
Okay. Anyone is having any question about the maternity dashboard, or should I go about like the slides? Okay, so maternity dashboard is basically a tool that is very important because it is helpful for monitoring the implementation of principles of clinical governance. So basically, the maternity dashboard, they say in their guideline that it's just like a car, it's just like a car dashboard, because in car dashboard we are able to see that when we exceed the temperature, we get to know that when the car is heating up, a red light comes out. So basically, it gives us a warning that something wrong is going to happen. So we immediately correct it. Or you can say that it is just like the signal system. Green means that all the goals are being met, which means that everything is fine. Amber means that the goals are not met, but currently we are not in the red zone, which means we are not in the danger zone, but we need to do something to stay in the green zone. So the red means that the upper threshold of anything is breached, and now we have to immediately take the action. Basically, it's based on traffic light system. If simply we simplify it. So we have to select some parameters like I showed you on the very right side, like cesarean section, the instrumental deliveries. These were the parameters. Benchmarking means that we have to set a standard. Like the goals were written over here, like the goal is written. So this is benchmarking. Some standard has been set already. Okay, so afterwards there comes, we divide it into green, amber, and red, and we monitor the maternity dashboard on monthly basis. These are some parameters that we go about. I'm going to explain each of them in I'm just going to mention about each of them. For example, in clinical activity, we can see that what is the number of admission, what is the number of deliveries, how many cesareans are done, how many instrumental deliveries are done, any transfers from the midwifery units. In the workforce, we can see that how many people took the sick leaves, what was the attendance, how many hours of consultant presence were there, In the clinical outcomes, we can see the maternal morbidities like eclampsia, failed instrumental delivery, shoulder dystocia, any anal sphincter injuries. In the neonatal morbidities, there can be different like Erb's paralysis, hypoxic ischemic encephalopathy, then ICU admissions. So all of these are basically the parameters that we can monitor, anything that we can monitor there. Okay, so afterwards come like who is responsible for it. First of all, like the lead midwife can do that, or anyone that is in the department who is a sensible and whom we can assign this task can do that. And everyone in the department that is related with the care of the patient, like the maternity team, the clinicians, the patients, we PGRs, all of us, we have an access to the maternity dashboard. So the Rubina was asking about the cons. So the only con is that it basically increases the manpower and extra load. Otherwise, it has advantages like it can promote, like there are different advantages. For example, a maternity dashboard can tell us that what is happening in our unit, and it can also tell us like sometimes people use it for comparison between two different units. For example, if we have two gynae units in our hospital and we are comparing their performance, we see two maternity dashboards, and by looking at them, we can tell that which maternity unit is doing better in what aspects. So it is also used for different clinics, like for different hospitals review, for different units review, like we can compare them, and for our own units benefit, how to improve the things this is used. So if anyone is having any question about the maternity dashboard, just let me know so that I can go on the audit topic. Okay, so I'm considering that everyone has got it because there are no questions. I'm sorry that the topic is a bit dry, but the thing is that clinical governance is always difficult to understand. Thank you, Sarah. The clinical governance is always a difficult topic to interpret in the exam. So that's why I've tried to like make the things simpler. But the fact that it is a dry topic stays as such. I am hoping that by the end of the session, I'm at least able to at least my students will be able to somewhat know about the things, and they will be able to crack the stations. And for the FCPS students, they will be able to at least say something about these kind of topics because they are coming in the exams nowadays. And for the MRCOG students, these stations are very frequently coming. One of the clinical governance station always comes in the exam. So it is very important. Okay, so now I'm coming to audit. And regarding audit, I will be giving you one example in terms that we have one example that we have to conduct an audit. So I told you in the risk management that whenever something is going wrong, we do the audit about it. I think you might remember the slide. Um, okay, so you can see over here that when we were talking about the risk management, we talked about one thing that when we are doing the risk management, the last step is that we do the audit about it to monitor the implementations. So now we are going to study the audit. Okay, so this is the audit cycle, and the audit cycle is basically having a few steps. First of all, we identify the audit topic. It can be any topic upon which you want to conduct an audit. Sometimes it happens that some things are going wrong in the department. For example, cesarean section rate is rising a lot. That's why we conduct an audit to see that what is the problem. Why are we having so many cesarean sections in our unit? So, by at the end of the audit, you are able to identify that what was the reason of more cesarean sections or any problem that was happening, and how we can correct it. Then we conduct a re-audit to see that whether we have corrected those mistakes or not. If I go about the steps, first of all, we identify any topic for the audit, then we set a standard. The standard means that any standard that is set on the national level, it can be an RCOG guideline, or it can be any national standard that we have set. Then after setting a standard, we start collecting the data, and I will tell you in detail that how we collect the data. After collecting the data, we analyze the data to see that what are the problems, why the thing is happening, and upon that we make some suggestions that these things should be done to make the corrections. And after suggesting the changes, we implement those changes, and we again perform an audit to see that whether all the things have that have or not right have gone right or not. This why I'm going to explain it. Okay, so today I am using the example of cesarean section to explain each and every step of the audit, because cesarean audit is a very famous topic in the exam. So audit means basically quality improvement process that aims to improve the patient care and outcomes, and it is done by measuring some practices against an explicit criteria and standards. Basically, it is a quality improvement process. If you just want to remember a small thing about it, it is basically a quality improvement process, and we set certain standards against which we measure it. So basically, it is a quality improvement process. So this is it. First of all, there is a difference between research and audit, because we know that what basically research is about discovering something, and audit is about the fact that we are doing it right, or we make sure that we make the things right. Whatever is happening wrong, we make it right. Audit is about improving a practice, and research is about discovering something. So this is the basic difference between these two. Okay, so there are different reasons for which we can conduct an audit. For example, sometimes there can be some structure or service about which we are conducting an audit. For example, I have given an example here that, for example, if some patient with ovarian cancer is operated by a gynecological oncologist, and she is managed with a multidisciplinary team. And so this is basically a structure of the service that is being provided. We can do an audit over that, or we can do an audit over some process that is happening, or we can do an audit over some outcome. For example, we give different kind of treatment to the patient, and we see whether the patient is having good results or bad results. So this is the outcome. So these are the three things based on which we can conduct an audit. First of all, measure of the structure or service, the structure or service that we are providing, any process any process like erythromycin in prom, or any kind of process that is a part of our clinical practice, or any outcome. So these are the three things based on which we can conduct an audit. So here again, I mentioned the cycle steps: selection of a topic, setting the standard, measuring it, implementing the changes, and re-auditing it. So first of all, the first thing is that we select a topic. And the most important thing is that we have to be very specific and selective about a topic selection. Because if you are going to involve a lot of things in selecting a topic, for example, you say that why the cesarean section rate is rising in primary gravida, why it is rising in multi-gravida, why it is overall rising, why instrumental delivery is rising. You select a lot of topics that are not sensitive and specific, it will not result in a good outcome. So you have to be very specific and selective. For example, here we will select that what is the reason that the cesarean section rate is rising. So this is our topic for audit today. So topic usually is from any of our common problems that we are encountering in our maternity unit, and any of the topic which is affecting us in terms that it is having a high mortality or morbidity. So the topic should be some common problem, and it should be something that is really affecting our clinical practice in terms it is affecting the maternal morbidity, it is affecting the maternal mortality. So topic should be like that. So first thing is selecting a topic. The second thing is sources. What are the different sources from which we can take the topic? It can be a maternity dashboard, okay. It can be some patient complaint. It can be some incident reports. So these can be the different sources for it. So after the source of a topic, then comes. Okay, so these points are very important here, because whenever you select a topic, you have to get an ethical approval, because every patient's data is confidential, and you cannot have an access to it without the ethical approval. So we need to get an ethical approval to gain access to the patient's notes. Then we have to set a proper team to select a topic. So this was the first part, that was selecting a topic. So whenever you come across any station in MRCOG 3 where it is mentioned that audit this topic, so first of all you will comment on how you will select the topic. You will mention that what things are in your mind before selecting this topic, where from where you will collect the data, who will collect the data, and the patient's information will stay confidential. So this is how you will comment on it. Then the second point is that we set a standard. As I already told you, that it is basically from the evidence-based guidelines, and from any local policy or any national policy is basically a standard. For example, now I'm talking about the cesarean section. So my standard will be that 21 to 26% of the cesarean section rate is a standard here. So now I will setting the standard, I will see that whether the standard is being met or whether the standard is not being met. And if it is not being met, what are the reasons behind that? So after setting a standard, so standard can be like anything. Okay, so benchmarking means any set criteria. Sometimes benchmarking is a question in MRCG 3, that what is benchmarking? So it is basically a level of care that is set, or any goal that is to be achieved. You can say it is basically a standard. Okay, so how we can collect the data? There are different sources, like there are different registers, there are maternity dashboards, you can directly observe it. You can take the staff interviews. These are the different sources. You know how to collect the data. You take the data from the patient, or you take the data from any kind of register, or you take the data from the maternity dashboard. So you know that. And who collects the data? Basically, if there are large projects, then all the people involved in the care do that. Okay, so this is an important concept regarding whether the data has to be taken in a prospective manner or a retrospective manner. Okay. Can somebody tell me what is meant by retrospective data collection?
Data which
It
is
means,
collected in the past.
yeah, from
Yes,
the
Maimuna, you're
that
really right about it. Anything that has happened in the past, that is a retrospective data, and anything that is going to happen in future is a prospective data. Now, retrospective data is generally an easier thing to collect for us because it can be easily taken from the maternity registers or simply the registers that we have. So it is easier comparatively. But there is one problem about it, that sometimes some data may be missing, because sometimes that data may not be entered at all and you miss that. And the prospective data is when you are taking the data in future, like you are going to take the record from this point onwards, further 6 months. So this is what we call as prospective data. Yes, Sarah, we can take it from the hospital record. Basically, we can take the data from any kind of hospital record that includes the registers that we have, that includes the maternity dashboard, incident reports. So all these are the sources of data collection for us. Were you asking that? This is what you meant, Sarah? Okay, so retrospective or prospective, we have to see about that. So when we are coming to the cesarean section, we will say that, okay, so generally telling that prospective data is always a better form. Okay, Sarah. Okay, so prospective data is always a better form because it gives us more information. But there is one thing, that sometimes it can be more time consuming, and sometimes there is some observational bias, like everyone's perspective differs from the other person. So the observational bias may come. Okay, so afterwards, okay, so one very important thing is that I just told you, that whenever you have to use the data of someone, we need an ethical approval. And without the patient's consent, you cannot take the data of the patient. And how we take the patient's consent? Generally in UK, what happens is that when the patient comes to you for any kind of procedure or any kind of problem, in the very beginning you tell the patient that you do take consent that this whatever will happen with you, we might use it for the research purposes and for the audit purposes. So usually the patients do agree to that. But if the patient's consent is not there, you cannot use the patient's data. Here, I am going to explain a very important concept that is called the Kelsey-Dot principles. So what is meant by the Kelsey-Dot principles? The Kelsey-Dot principles basically mean that only the patient is having access, complete access to her data, And however, for audit purposes, we can use that, but with her permission. Now, what we should do, that we should justify the purpose. We should only use the data when it is necessary, and we should use the minimal data, and only the data that is required for this specific audit we will take, that we will not touch the remaining data. So these are the Kelsey dot principles that basically tell us that the patient has the full right over her all the records, and none of the persons apart from patient has the full authority over her records. But if we have to use this data for any kind of purpose, then it is very important that we justify the purpose, and we only take the data that is necessary and that should comply with the law as well. So these are some Kelsey dot principles that are an important part of MRCG 2 and 3 exams. Okay, so then about the data, we should be knowing that what number of cases that you are going to take. The duration of study is very important. For example, we are talking about the cesarean section. So we will say that we will study the cesarean section rate for coming 6 months time, and we can do the exclusion or inclusion criteria as well. Okay, so there are different ways to collect the data, like there can be performers as well. There can be IT spreadsheets as well. So all these can be there. Okay, so after doing this, like after the data collection, you compare them with the standard, and then you can come to the thing that whether the data that I have collected, this is complying with the standards or not. Okay, so if I am talking about the cesarean section rate, the topic I took was cesarean section. The standard was that 21 to 26% should be the cesarean section rate, and it should not exceed it. The data I collected was, I wanted to collect the prospective data. I took the ethical approval. I defined a sample size that was 6 months study. Now in the data, there comes that what can be the reasons for the cesarean section. When we are discussing a case like cesarean section, we will mention that we will see that what are the reasons that why cesarean sections are rising. Like there can be some instrumental deliveries, there can be some vaginal birth after cesarean, that's why the cesarean section rate is rising. There can be some breach, there can be some CTG problems, there can be some maternal requests. All of these are indications for a cesarean section. So when we talk about analysis of a data, then we analyze each and every factor. For example, I told you different factors. For example, first of all, I said that instrumental vaginal deliveries are having some difficulties. That's why cesarean section rate is rising. So when I will analyze this data, I will say that because an instrumental vaginal births are rising, so I will see that whether the training of the trainees is required so that they are able to do the instrumental deliveries in a better way. Similarly, if the problem is that the VBAC is there, the vaginal birth after cesarean section, the patients usually do not agree to that. So for vaginal birth after cesarean, how can we reduce this risk? We can do proper counseling of the patient, and this is how we can reduce the vaginal birth after cesarean. We can increase the vaginal birth after cesarean, and we can decrease the cesarean risk. Then one of the reasons can be breach, due to which the cesareans are being performed. So for breach, we have to enhance the training of external cephalic variant. Then we have to do the timely ultrasound scan so that we are able to diagnose the breach. And we have to train our trainees for the breach diagnosis so that the cesarean section rate is decreased. So this way you will take all the reasons and you will explain each of the reason, that what can be the reason and how can we do the correction of this reason. What can we do for this reason so that we are going to improve this practice. For example, if I say that CTG is one of the reason for the increased cesarean section, then we have to train our trainees to properly interpret the CTGs. Sometimes there is maternal tocophobia, like the patients don't want to go for a normal birth. So this can be one of the reason for cesarean. For this reason, we have to counsel the patient. We have to connect her to the psychotherapy. We have to address all her concerns. So this way, whatever topic is coming in the exam, just tell about that why this problem is happening and what we can do for this problem. I hope I'm clear about the things up till now. Let me just go over the points once again. Like first we have to select a topic. I hope I'm clear about the topic selection, that from where we have to take it, we need the ethical approval for it, and we have to set a standard second point. After setting a standard, then we have to collect the data, which can be from different sources, and it can be prospective or retrospective, and it should be confidential. and about the sample size. So after that, we do the data analysis, which means we identify the problems, that what are the problems and how we can correct them. And after we come to the thing, like after we come to know that what are the problems, then we have to implement these changes. Like I told you that if there is instrumental vaginal birth increasing, we have to implement the thing that we should be training our trainees. If there is breach increase, we should increase the training on external cephalic variant, we should increase the training on ultrasound scans. And this is how we implement the changes. And after implementing the changes, it is very important that we disseminate them to the people through different board meetings. We carry out different presentations, we carry out the feedback sessions, we carry out the different, like we send the people through emails. Like we will mention them that what things have we implemented, we want to train the trainees on different aspects, we want to improve these things. So we have to disseminate these things through the emails and through the feedback sessions. So this is how we implement the changes. And after we implement the changes, then we plan a re-audit. Re-audit means that whatever you have collected the data, whatever things you have corrected, we are going to do a audit again after 6 to 12 months, so that we can see that whether the things that were going wrong in the department, whether they have been corrected or not. Coming to this case, we will see that, okay, so now the cesarean section rate was rising. Now we will see after 6 to 12 months that after training the people in the instrumental vaginal birth, after training the people in external cephalic variants, after training the people about CTG, after proper counseling of the patients regarding VBAC, after counseling the patient regarding tocophobia, whether we are able to achieve the rate now or whether we are not able to achieve the rate. So re-audit means that again the audit has to be done to see that whether we have achieved the standard or not. Okay, so there are different reasons due to which our audit can fail. Like there can be resistance to change. You know, this is a chronic problem with everyone. Sometimes the trainees rotate to other departments, and that's why they are unable to complete their audits. Sometimes there is lack of interest. There is not much supportive environment. There is lack of time. There is lack of cost. There is like patients sometimes themselves do not prefer to be a part of audit. So these are all the reasons why the audit can fail. So is anyone having any questions about the audit, please? Is anyone having any question about the audit? Any steps of audit that are not very clear? Okay, so regarding the audit, whenever any topic will come in MRCG3 exam, what you have to do is that take this topic and apply all the components on that topic. For example, selecting a topic, cesarean section was my topic, setting the standard 21 to 26 national standard, then collecting the data, what data are you going to collect, what things can increase the cesarean section rate, you will include all these, then how you have to implement the changes and how you have to re-audit. So whatever topic you will be having, you will be implementing these points on that, so that you will be able to solve it. Well, Eden, I will try my best to make this recording available on the ASMR CUG page. I am typing it here, the name of the page. This is a Facebook page, and by tomorrow, just a second, please. I'm typing the group name ASMRCUG on Facebook. On this page, by tomorrow or the day after tomorrow, this recording will be available. So is anyone having any kind of question? Because I have heard that in FCPS exam as well, last days the breach came as a like audit as a part of audit. So if any topic comes like that, you have to select the topic that why the breach is increasing. You have to set the standard that how much should be like, what should be the standard regarding the management of the breach, when should it be diagnosed, You have to mention about all the risk factors that can be a part of it. Then you have to see that if the breach was not diagnosed, what were the reasons the breach misdiagnosis, one of the reasons can be that the ultrasound scan was the person was not trained for the ultrasound, or the patient missed their visits to the like maternity unit, or sometimes it can be the negligence by the patient and by the unit both. So these can be some of the reasons. And what can we do about these reasons? We can simply train our trainees about the training. We can give proper counseling to the patients for visiting us in a proper way. And afterwards, we will re-audit that whether other breaches are missed or not, like whether we are able to identify all the breaches or not. So any topic can come and you can simply follow all these steps, and you can simply solve this station, because there is a lot to speak about it, speak about anything in the, like, I have given you a lot of material regarding what you have to speak in these kind of topics. So whenever this kind of topic is coming, just go step wise, take each step, and according to that specific topic, just mention about the specific things in that topic, that how you will collect the data, how you are going to assess the data, what things are you going to look for, what things you are going to re-audit. So this is how it goes. Is anyone having any question? Just ask me. I am going to take the last topic for today after this one. Okay, so another very famous question for MRCUG3 is the appraisal of audit. Appraisal of audit is all about audit. It means that an audit paper is given to you and they say you to critically appraise it. Whenever we have to critically appraise something, it is very important to remember the steps of that specific thing. For example, for the appraisal of audit paper, we have to remember the steps of audit. So it will make it quite easier that we will simply start by audit steps and we will appraise each step of the audit time wise, like one to one. In critical appraisal, we have to mention what is good, what is bad, and what things can we do so that it gets more better. Okay, so I'm giving a critical appraisal of the audit here. So basically an audit was done for the shoulder dystocia in the department. And these are the details, that what details were mentioned. It was carried out for 6 months time. And the result was that as a result, 50% were able to normally deliver, 25% had instrumental deliveries, 30% vacuums, 25% had a shoulder dystocia. And there are some things like paralysis, poor documentation, performa filling, neonatologist presence. So these are the things. Basically, this is the audit report that is given for critical appraisal, that what things are correct in this audit report and what things need an improvement in this audit report. So I'm going to do the critical appraisal of the audit. Okay, first of all, we will identify the strength and weakness and we will go into each step. Okay, so first thing, you remember that in audit, the first thing was the selection of a topic. So when we are critically appraising the audit, means this audit we are critically appraising and the topic they selected was shoulder dystocia. So let's appraise this audit. Okay, so first of all, we will see that what was the importance of this topic, what was the aim of this audit. So the topic was shoulder dystocia, and the aim of audit was that the shoulder dystocia was there, so that's why they did an audit. The topic's importance we will appraise in such a way that it is an important topic, because it can happen in, like, in 50% of the cases the reason is not even known for the shoulder dystocia, and it is an obstetric emergency as well, so it is an important topic. Then we will see that whether ethical approval was obtained or not, what were the team members, and whether the seniors were involved in that. So here you can see that the ethical approval is not mentioned, that whether it was taken or not, and it is not mentioned whether any senior was there or not. The neonatologist was only in 50% of the cases, but in other cases, none of the seniors was there. So you can say that in this audit, the topic is important, but the ethical approval was not obtained, the team members were not involved, and the seniors were not involved.
जो भी होशी है ना, असल में आपका मसला ये है कि मैंने आपको जरूरत से ज्यादा मालूमात दे दी हैं, मरीज परेशान हो जाते हैं ना। मैंने ये कहा था कि सबसे पहले
Okay, so now we are seeing that what about the standard selection? What was the local protocol up to date with the national ones? What was the source and what was it evidence based or not? So basically, we can see that whether the audit that was done that was in compliance with the Green Top guideline number 42 on shoulder dystocia or not. So we can see that. Okay, so afterwards comes the data collection. We will see that what was the sample size because it is not mentioned here that what was the sample size. And we can see that it was a retrospective data. So we can say that retrospective data was used there, but prospective data is a more better form. Then we will mention that the performer should be simple. The inclusion and exclusion criteria should be there. Like, in shoulder dystocia, we should be mentioning about the inclusion criteria that if the body is not being able to deliver in like 60 seconds time, we can set this criteria or we can set any criteria that whatever the criteria of shoulder dystocia is, we will mention here that this is the criteria. And if any delivery is following this criteria, we can include in that. Then we will see that whether Kelsey dot principle, which means the patient's confidentiality was maintained, whether the ethical approval was taken, and whether any important data was missed or not. So this is how we collect the data. Okay, so data collection in this specific case, it is a case of shoulder dystocia on which audit was done. So a lot of information is missing on that. So whenever you have to critically appraise any audit paper, simply see that what things are missing in this paper because these are the strong points for you to build whole of your presentation on it. Like we will see that the risk factors are missing if they are not mentioned. These are all the risk factors that can be in the case of shoulder dystocia. So we will see whether the risks were addressed or not, whether induction was done in GDM, whether elective section was done in if the baby was more than 5 kilogram, whether there was any history of dystocia, because all this information is not available in the audit. So this means that this was not these things were not assessed at all in the audit. Then we will see that what about the intrapartum events? How did the shoulder dystocia, how was it diagnosed? Was there call for help? Whether maneuvers were done? Whether episiotomy was given? You can see in audit paper that none of these is being mentioned. So whatever is not mentioned, you have to mention it that these things are missing. Then we have to mention that, for example, in shoulder dystocia, what was the time of delivery of head, when the help arrived, when the body delivered, when the anterior and posterior shoulder delivered. So because in the audit, these things are also not mentioned and these are very important in shoulder dystocia. So whatever topic you get, just look at the things that what are the important things in this topic that are not that are not written in the audit paper. This means that those things need to be mentioned. Then you can see that a few maternal complications are written in the audit paper. Actually, you can see here that PPH is mentioned. Same way, Earth's paralysis is mentioned. But the shoulder dystocia has so many complications for the mother and for the baby. All of them are missing. So you can mention them. Like you can say in maternal complications, these are missing. In fetal complications, these are missing. The incident reporting is not done. Documentation is not done. Debriefing is not done. So you can mention all of this. And then comes the recommendation that so in documentation you will be simply you will go simple. You will mention about the simple changes, achievable targets, and agreed time scale, because you can see in the previous audit there is no time scale given that when we are going to re-audit. So these are all the things that we will do in the re-audit. We will see whether there was a suitable interval given, whether the things were suitable or not, whether the changes were implemented or not. So all these things, whatever is wrong in the audit, you just have to pinpoint that thing, and for that you need to know that what is audit. Once you are very clear about audit, you can easily solve the appraisal of the audit, because it simply means that you have to be critical and you have to criticize the audit that whether it was correct and what things were missing. So in the end of the appraisal, you should simply conclude by you should simply be saying that there should be adequate data because the data is missing. There should be a good performer. There should be some agreed recommendation. There should be some changes. There should be appropriate time frame allowed for the implementation of changes. And there should be a time that is defined for a re-audit, that when we will when we will do the re-audit. So if I'm going to talk about the critical appraisal of anything, I will simply point out the mistakes in the audit that were done, and you can simply like you can mention the mistakes only when you are familiar with the steps of the audit that I just mentioned. So appraisal is not difficult. It is simply following the steps of audit. Is everyone clear about it? Okay, so is anyone having any questions before we conclude the session? Yes, Arif, basically we do mention the good things as well. Like in this audit, that's a very good point that you have raised. We don't only talk about the negative things, we do mention the positive things as well. Like in this audit, we will say that, okay, so most of the things are negative here, that's why. But you can say that, okay, some complications have been mentioned, like earth paralysis has been mentioned here, so that's a good thing. But apart from the earth paralysis, the other complications were to be mentioned as well. Similarly, PPH is mentioned, that's a good thing, but other things should have been mentioned in this as well. So whatever the good things are, you will highlight them. But in the performer I have got, unfortunately, I don't have a lot of good things. So the performer you will get, you will see the good things, you will comment on them, and then you will mention about the bad things that are there and that need the correction. Arif, I hope I'm clear about it. Yes, side by side, Arif. Any other questions? I know it's a very boring topic. Like I am well aware that this is a very boring topic for everyone. But the audit has been coming in the past lot of exams, so you should at least know the steps. And because this will give you some words to speak. If you are very well aware about the steps, then you can simply kill your station by simply speaking all the steps and taking them side by side. Okay, so basically in PILS as well and in the research paper as well, the critical appraisal is there. So critical appraisal again involves these things that we will see in most of the articles. We see that what are the references in this article, whether the references that are given are correct or not. Then we do some simple steps that whether they are up to date with the knowledge or not. Like we do follow the steps of audit, but not exactly in the order of audit. Like we see the data, whether the data is correct or not. Let me, okay. So Sarah is basically asking that when we get a research article, critical appraisal, how do we do that? Usually in MRCUG3, the research article will not come because it is not a very vast topic. Sometimes the PILS appraisal is also does also come. But whenever we have to do the critical appraisal of these things, we start by the data. Like we see that what kind of data is there, whether proper appropriate data is there or not, whether the research article is according to the recent green top guidelines or whatever guidelines you are following, whether it is according to that or not, whether it is written in a good way, whether all the aspects in the research article are covered or not, whether it is in a legible handwriting or not, whether any diagrams are included or not, whether it is easy to like easy to interpret or not. Like you will take the research paper and you will appraise on all the steps of it, starting from the data collection, the method of data collection, that may be retrospective, prospective, or any kind of study. Then after the data collection, you have to see that whether what members are included in it, ethical approval has been done or not, whether it is legible, whether it is up to date with the recent guidelines or not. So these are all the common steps that we do in any kind of critical appraisal. Am I clear about it, Sarah? Okay, so for research article as well, I'm going to give you some like lines if you want. For example, you will see about whether the study is a weak study or it is a good study in terms whether it is up to date with the guidelines or not. and you will see that whether it is a valid study or not. Then you will see that what is the basically you can say the interpretation of that. You will see that whether it is relevant to your field or not. You can see that whatever topic is given there, whether the research questions are being asked, whether there is any research performer attached with it or not, and if the research performer is attached, whether it is in a simple language for people or not, and all the questions that are a part of that research article are attached in that performer or not. And you can see the study design as I already mentioned you. So these are some ways to like critically praise a research paper, you can say. Okay, so is anyone having any other questions? Okay, so if anyone is having any questions, just let me know before we finish it. Okay, in the coming week, I will try to take a free session on the POPQ as well, hopefully, and it's going to be less try, hopefully. Okay, Dr. Aisha, then I'm going to do that for you. Okay, so I'm going to go a bit quickly over it. Also, Dr. Aisha, the recording will also be available, but I'm going to revise it for you that the critical appraisal of the audit means that you have to basically an audit paper is given in the critical appraisal, and you have to appraise, you have basically to mention the things that are not mentioned in that kind of audit paper. Whatever kind of study you are taking, whatever topic you are taking, for example, this is a audit that is on shoulder dystocia. So we will see that what are the good points in this audit topic and what are the bad points in this audit topic. This audit topic has a very limited information, like this tells us that this is for 6 months. This tells us that how much was the normal delivery, how much was the forceps delivery, vacuum, dystocia. This tells us the complication of the baby. Only one complication of the baby is mentioned. Documentation was poor documentation is mentioned. Performer is not properly filled. A neonatologist was present. So these are the things that are given in the audit. So stepwise we will take the, like we know the steps of audit. So taking stepwise the audit, we will be able to tell that what things are wrong in this audit. For example, we start with the topic. We see that the topic is shoulder dystocia and we know that it is a very important topic, so the topic selection was good. We will see whether the ethical approval was obtained or not and whether the seniors were involved in this or not, because in audit it is not mentioned that whether the ethical approval was taken and whether the team members were involved or not. So these the things that are not mentioned, you can highlight them. Then we will see that what is the standard selection. So green top guideline is our standard method of selection. You know the green top guideline number 42 is on shoulder dystocia. So then we will say about the data collection that it is not mentioned that what was the sample size and the study was retrospective. Then we will see that whether the performer that was designed for shoulder dystocia was appropriate or not. Then we will see that whether Kelsey dot principles, which means the patient's like confidentiality was ensured or not, the ethical approval was taken or not. Basically, all these things are not mentioned here. So whatever is not mentioned here and is a step of audit, you have to mention that this is wrong in this kind of audit. Then the risks to the baby are not mentioned. The risks are not addressed here in the audit. The intrapartum events like who diagnosed it, call for help was there, maneuvers, episiotomy, none of the details is given in the audit. So you can mention that these details are not mentioned in this audit. So that's how you are critically appraising the audit paper. Then you will say that none of the record is available. When was the head delivered, when the help arrived, when the body delivered, when were the anterior and posterior shoulder delivered. So none of them is mentioned in the audit paper. Then only the PPH is mentioned in the complications. That is a good point, but the other complications are missed. Similarly, fetal complications, only nerve injuries mentioned, all the other are missed. So you will mention that. Then you will mention that the incident reporting, documentation and debriefing, all whether they were done or not, that data is missing. So whatever things are missing there, they should be like we should make a conclusion that the data collection should be adequate. There should be a performer. There should be proper agreed recommendations. The implementation of changes should be proper. there should be a suitable time frame that should be allowed to practice the changes or to perform a re-audit. So by going like audit, appraisal of audit is basically a mirror reflection of audit. Whatever are the steps of audit, you will see in that report that you have, that whether all the steps are being followed or not, and the steps that are not followed or the information that is missing, you have to mention that. That is basically the critical appraisal of the audit. Any other questions, please? If anyone is having any questions, please let me know so that I can send, I can finish it. Okay, so hopefully this recording will be available on the website, not on the website, on the Facebook page of ACMRCUG in coming 1 to 2 days. Thank you, Dr. Sadia. Thank you, Dr. Aisha. Okay, thank you so much, everyone. Thank you, Shaista. Thank you, everyone who was there to listen to it. But I know this is a very dry topic, but I just tried to like highlight the points so that whenever you get a topic of audit or appraisal of audit, you are at least able to speak something about it in 10 minutes time. So I hope you will looking again at these slides and you can take the slides so that it is like easy for you to fill the words, because these stations are difficult ones. And hopefully I will be arranging a class on PopQ like in the coming week, or in the after 2 weeks. I will be doing that. So I'm really thankful to everyone who has participated here today, and thank you so much for the time. And wish you all the best for the exam. For the FCPS candidates, wish you all the best for FCPS, and for the MRCUG candidates, wish you all the best for that. Goodbye.
Thank you so much, ma'am.
Thank you so much.